Hi, I'm Ben Massenberg. I'm a plastic surgery resident at the University of Washington, and I'm here with Dr. Jesse Taylor, who is the Peter Randall Chair of Plastic and Reconstructive Surgery at the Children's Hospital of Philadelphia. Welcome, and thank you for joining us today.
Thanks for having me, Ben.
And today we'll be talking about syndromic craniosynostosis. So to start our discussion, what do you think have been the largest paradigm shifts in care for patients with syndromic craniosynostosis since you've been in practice?
Well, and just to back up my appreciation for asking me to do this, Ben, I want to wish everyone out there in the craniofacial world the best, and certainly have been missing everybody and can't wait to be together in Seattle. What are the couple of the biggest paradigm shifts, I think, in my career? One has been, I think, a paradigm shift towards posterior cranial vault distraction is sort of the first cranial vault expansion in kids with syndromic craniosynostosis. And then probably the second is a more critical analysis and perhaps a more complex execution of mid-phase surgery and that period of mixed dentition. So expounding a little bit about posterior cranial vault distraction, I think a lot of people have bought into the fact that it's a bit of a lower morbidity procedure, can be done perhaps in a slightly lower age because of that. The volumetric expansion and the slow gradual stretching of the soft tissues overlying the bony regenerate, and the benefits that we've seen, for instance, in the orbits when we do posterior cranial vault distraction in young syndromic patients. And then third, its ability to really mitigate frontal surgery until we do mid-phase surgery in the period of mixed dentition. And certainly that's not in all kids with syndromic craniosynostosis, but in a growing number of patients, we do a posterior cranial vault distraction in infancy. And then the next surgery that patient has with our group is 5 to 9 years of age, undergoing some type of mid-phase advancement procedure in which the forehead is also moved. So our group has recently looked at our morbidity with mid-phase surgery in kids who haven't had prior frontal surgery and seen a significant decrease in morbidity from those procedures, which makes sense. I mean, there's less surgical scar, less chance of a ascending infection in those instances. So I think posterior cranial vault distraction has been a game changer. I will say it's a step in the evolution, and I don't expect that would be the same thing I would say in 10 or 20 years from now. I'm sure I'll be saying something different. And then, I really give Rich Hopper, our president, David Dunaway, and others who have more critically analyzed the differences in the syndromic midphase between syndromes. And as a result of that critical analysis said, there may not be one operation that fits every patient. It's not that every single patient needs a monoblock or every single patient needs a LaFort 3, but in fact, there are many different ways we can osteotomize the midface and tailor it to the deformity or the deficiency that exists in each patient. So that's a long-winded answer to your question, but I would say those are the two biggest things I've seen.
Great. And seeing kind of the shift in care from a treating syndromic craniosynostosis as a whole to breaking down by syndrome and maybe to the future by kind of genetic mutation. What are the biggest challenges that we are facing as a surgical field for taking care of these patients with syndromic craniosynostosis?
Oh, a tough question. And I don't know that I know the answer to that. I do think there's a challenge relating to diagnostics that is being met, I think, with increased sensitivity of our genetic markers, because I think it built into your question is the fact that not every Apert syndrome patient behaves like every other Apert syndrome patient. And in fact, with two dominant mutations, you likely have at least two, if not more than two groups of patients who we sometimes lazily refer to as a monolithic group when it's not. Pfeiffer, an even greater range of presentations based on different, at least three subtypes, And then with Cruzon, at least 2 to 3 subtypes in the common mutations. And likely there are epigenetic effects going on that we have yet to measure adequately. So part of our challenge in treating this group of patients is that we have lacked diagnostic sensitivity, and as a result, we're likely referring to disparate groups of patients as being the same, who are not actually the same. So, so I think built into your question, there's no doubt in my mind that one of our biggest challenges is in diagnosis. And those diagnostic challenges make it that much harder for us to direct treatment.
Great. And so kind of with those challenges, where do you think we are heading in the future? And what are you most excited about for the future care for these patients with syndromic craniosynostosis?
Well, the answer to that question is why we're all traveling to Seattle in a few months. I learned so much when I go to these meetings. They're actually my favorite meetings of all the meetings I attend is the ISCFS, because I feel like I don't know the answer to the question you asked, but each time I go to one of these meetings, I get closer to at least knowing maybe how to ask the questions and maybe investigate how to answer some of the questions. But where are we going in the future in syndromic craniosynostosis? As we already touched on, I think the diagnostics are going to get much better as the diagnostics genetically and epigenetically get better. It's a hope, and I think it's a reasonable hope, that there will be medical therapeutics that can be brought to bear, potentially not always to treat or prevent the problem, but to maybe affect its natural history. So for instance, if we can figure out how to drug one of the various FGFR2 mutations, maybe the profundity of the midface hypoplasia will be different. Maybe the severity of the cephalocranial disproportion will be less severe. And so I think drugging various genetic pathways is going to be an exciting path for the future. So I think we have a long ways to go there. And then I'm kind of as a goal in my career is to try to find less invasive ways to achieve similar outcomes for our patients. So less invasive ways of doing cranial vault expansion through endoscopic means, less invasive ways of moving the bones to create less scar through distraction osteogenesis, and potentially more intricate ways of analyzing what we're doing both pre and post-operatively, so that we can basically create a more normal life for these kids who arguably we still are falling short of that goal of getting these syndromic patients both functionally and aesthetically fitting better into society.
Yeah, well, certainly I hope we can achieve some of those goals in the future. And thank you so much for your time, Dr. Taylor. I look forward to seeing you at the meeting in Seattle.
Thanks, Ben. And again, I wish all of our colleagues out there the very best in 2023 and beyond.
Thanks.